and welcome back to the Advancing Healthcare Innovation Show. And I'm your host, Michael Stamatinos. And if you're new to us, we're super excited to have you here. You know why? Because we're bringing very exciting conversations with prolific leaders that are painstakingly changing the future of healthcare. And we're really passionate around leadership, execution, access, and innovation adoption. So if it's your first time tuning in, let me just sort of take a step back and just tell you a little bit about what we're trying to do here. So we're a healthcare innovation company, and we're focused on bringing stories of innovation to life, not just the things that you hear about in theory, the things that are actually being done, that have been done. And the aim is to actually highlight real people that are in the trenches, that are doing the work, and just giving them the capacity and the space to be able to share what they're doing with our community. So if you haven't checked out any of the historical content, make sure you do that. But if you want to get any of the new episodes coming directly to your inbox, just make sure you hit the subscribe button now, and you'll get any of the new episodes that come to you. And as part of our commitment, just to continue to keep you updated with the latest and greatest of the advancements and solutions that are out there, we've got a pretty amazing, innovative leader and a special guest today, someone who spent more than 35 years working in healthcare in a wide range of leadership roles, and she knows what it takes to innovate. So please welcome Laura Zehm. She's the former CEO of Aspire Health Plan, where she actually led the creation of the health plan and advanced several partnerships with local health systems. And at her core, Laura, she really cares deeply about her community and knows exactly what it takes to contribute to access on multiple levels. And she's really sort of improved community health while lowering costs. And it's really a very applaudable achievement, especially in today's challenging healthcare landscape. So prior to Aspire, Laura was Chief Financial Officer at Montage Health. We'll dig into a little bit of her history, but she really can kind of showcase how she leveraged her extensive knowledge and strategic operational capabilities to really guide the evolution of an integrated healthcare delivery system in Monterey County. So Laura, it's great to see you again, and it's an honor to have you on the show.
Thank you, Michael. Thank you for that wonderful introduction. I'm really happy to be here and share what I've done and what my team and I have done together.
Yeah, and not only that, but I mean, you still got a lot more in you. So I think we want to also talk about the future in terms of where you see innovation headed. Let's maybe take a step back for a moment and talk about innovation from when you started out earlier in your career. What did that look like? How did you define innovation? And throughout your career, did that definition evolve at all?
Well, and I didn't start out thinking about innovation per se. I started out thinking about what was going on in our community. So 12 years ago or so, our community, as they still are today, we haven't totally solved the problem. We're struggling with increasing healthcare costs, premiums continuing to go up. Our local employers came to us and said, we need help, and can you help us? And the first thing we did is we said, well, we need to take costs out of the hospital. By the way, at that time, our healthcare organization was a hospital. That's how we identified ourselves. I was the CFO for a hospital. That's what we did. And when our community came to us and said, we really got to, we really need your help. First of all, I was really happy they came to us as opposed to going around us or coming up with another solution. And the first thing we did, we said, we have to cut costs out of our own operating budget or nobody will take us seriously. So we did that. We took 12% out of our annual operating budget. It was a big chunk. But the result of that was that the premiums did not go down for anybody. So I think that gave us credibility, but it didn't really solve the problem. So I sat down with our chief medical officer. So this is where it came from. It wasn't, again, sort of this innovation idea. It was, how do we really reduce the healthcare spend for our community? So the only way that I could see, and in my opinion, the only way this can really be done is to reduce unnecessary expensive healthcare spend, right? Hospitals are never going to be cheap. They're never going to be inexpensive. So the real answer is keep people well, keep people out of the hospital as much as you can, and then pass that on to the community. So we need to pay ourselves to do that. We couldn't, our whole model, hospital traditional model,
Yeah.
fee for service is the sicker people are, the more people show up and the more revenue you have. So we said, all right, we need to come up with we need to think of every single way we can to pay ourselves to keep people out of the hospital. So we decided that we talked to insurance plans to partner. That question has come up. At that time, there really wasn't interest. We couldn't wait. So we started our own insurance company. So I led the development of an insurance plan. Our biggest loss was Medicare. So we started with a Medicare Advantage plan. That was
Right.
our first off, right? So in building, so it was really
What did it take though internally? Let's like what did it take internally for you to say to your peers, "Hey, let's just start an insurance plan. We're in the health, we're in the hospital business, and now we're going to be an insurance plan." Like,
yeah,
how did
that's
they
great.
take it? What did you have to do to get them to kind of get buy-in?
Well, so fortunately, this my CEO is a very smart, very forward-thinking person. So I went to him first. So me,
Okay.
medical officer, we mapped out a plan, and it truly we sat in the backyard one afternoon because we were both like, okay, we got to go to our CEO with some outline of what we think we can do. So we did. We sat there and we mapped it out, and we went to our boss and said, "This is what we think we need to do." And to his credit, he said, "Yeah, I think you're right. I think the time is right." You know, and so we spent the next 6 months developing the story to take to our board of trustees. So, right, because that's what we had to do.
Yeah.
Because now we're saying, yeah, we are doing well financially as a hospital. By the way, we were and still are that hospital. And now we're going to take this big financial and business risk. But we painted the picture to say, what would happen if we don't do this? That's how we sold the idea to our board. We said, we think, in 10 years or whatever, we're going to continue to pass along really high premium increases will be passed along to the community. If we don't solve this problem for our community, somebody else will. And we're not going to like the answer. We spent 2.5 days. We walked the board through sort of a storyboard, if you will. We told the story from here's what we are today, here's what we think the future looks like, here's what we think, what the future for us could look like if we go down this road, here's what it looks like if we don't. And at the end of a 2.5 day retreat, they said, yes, go forward. So there was a lot of thought and planning that went into settling our board on the idea. We didn't just show up one day and say, "Hey, let's just."
Yeah, there's a lot of footwork, there's a lot of energy expenditure, getting all the right things aligned, mapping out
Mhm.
the strategic vision. But I like what you mentioned. It's like, well, what happens if we don't do this? What's the
Right.
opportunity lost here? And oftentimes, do you find that when you're trying to push a new idea or to get something done, do you lean on that? I'll call it the psychological trigger of fear. Like, what if we don't do this? What happens here? Where do you find people move faster? Do they move faster if it's from a fear of loss, or like you know what I mean? Do you know what I'm saying with respect to that?
I do know what you're saying, and I love the question, but I hate doing anything out of fear. And in fact, that's one of the things that in my career I've often said: if we're doing this because we're afraid, then let's not do it. It was more the conversation about we're a nonprofit hospital. Whatever assets we have belong to our community, not to us. So if I was a community member and I'm sitting in this room, and by the way, that's what a board of trustees for a nonprofit is there to do, to represent the community, right? So
That's
I
right.
saw that I said, so you're sitting in the seat of our community. Do you think our community wants us to invest in keeping them healthy and keeping them out of the hospital? Yes, they do. So it was that. It was, and I didn't, I wasn't going to stand up there and lecture them on their job, but it was implied in the materials that were presented, right? That this is the best thing for the community. And by the way, we had also just been through a contracting cycle with one of the major insurance plans that was, we really didn't have a lot of leverage, and we ended up giving a lot of revenue. And on an annual basis, we had just cut costs, so we could afford it, but that was also going to keep happening. So that was part of the picture I painted. Not so much fear, but that this is the current dynamics between us and our insurance plans. It's adversarial, it's who has more leverage to win the argument. So the other part of this was to say, how do we how do we become partners with the insurance plans? How do we, and that's an ongoing, I mean, that's still ongoing today, because you'll have certain plans that at one point in time, because of their executive team, are all in on that. They're like, great idea. Then the key executives change, and then they're back to this adversarial model. So that can also change over time. But we found
Right.
some good partners that said, yeah, we want, we like what you're talking about. So I'm fast forwarding a little bit, but once we built this insurance plan that also had a population health company attached to it, right? Because we said we're going to take the risk, and we also then have to manage it, right? Then we really do have to keep the population well. We have to execute on both. We have to execute on how do we pay ourselves, but we also have to execute on how do we keep people healthy? How do we keep people out of the hospital? So we had both pieces, and they're still there. But as we did that, we had a very early partner in one of the major plans, the same one, by the way, that had beat us up a few years earlier, right? But you can't hold grudges either. You just have to say, can we work together? Yeah, great. Then let's try it. And we
Yeah.
formed an ACO with that plan. I mean, it was just all ways for us to start learning how to do this work, because that's a huge part of it. It's learning how to do it, what works, what doesn't work, and building that platform for that. Then it became innovation, right? Because then we're like, okay, how do we keep people well? Well, let's try some different levers. Then you can innovate.
So how long were some of these experiments when you ran experiments? Because what it sounds like, what you're doing, quite frankly, is these are a lot of the ups and downs of what many emerging companies are dealing with. Yours was obviously done underneath the umbrella of, a larger entity, but in essence, you were an entrepreneur, with the backing of a larger entity, but you're still acting like a startup, in a sense. So
That's
talking
right.
about maybe some early experiments, maybe that didn't necessarily go as you had anticipated.
Okay. So even before we started the health plan, that was, that's an actual full licensed health plan, we formed a stop loss captive that failed. So I had an early failure in the risk business. Hospital CFOs aren't really educated traditionally in insurance risk, right? That kind of capitation risk, unless you're taking a lot of it. So we thought we'll get a bunch of local employers together. We'll share stop that are self-insured. We'll share stop loss risk together. And part of that is we'll work together on, again, these ways to keep our employees and dependents healthy. This community wasn't big enough for that kind of risk. And it was not, and it was similar risk, right? So you didn't have a lot of good diverse risk that you were bringing in. Okay, the early failure. We did it for a couple of years, and we said, you know what? This isn't working. Close it. So we closed out the captive. So that was one. I said that was our biggest failure, but it was really an important learning.
Yeah, how
So
did people and the teams kind of perceive that experience? Because I think sometimes it depends on how you perceive failure. Are you perceiving failure as the end all be all, or are you perceiving it as it's a data point, it's a learning point? How are we going to improve from it? How are we going to get back on track? Talk about that from a cultural
yeah,
perspective.
so I was fortunate enough to have a board of trustees also that had some innovators on there. Some of our board members, private equity people. Some of our board members are people who had invested in other startups that then became big companies. So, and in fact, when we started the Aspire plan, our board president was still is today, an innovator himself. So when we went to them and said the captive didn't work, those members of our board actually valued and appreciated that we learned and felt quickly, right? That we didn't try to hang on to the captive and try to make it work and struggle with it. I understood very early on, here's what we learned. This pool, this community here is not big enough to spread the risk. It's too
How big was the
concentrated.
community? How big was the
Well, the
community?
community here is, I don't know, let's just say we're 600,000, but there aren't that
Okay.
many self-insured employers. So
Right.
when you take a small pool, right? So we just, and other stop loss captives, I think have been successful, but they've been huge regions or maybe even national, right? So very different kind of risk. So, and plus by being um, involved in this captive and forming it, I also started going to insurance conferences, right? So I was being introduced to different people who had way more experience at this than I was. And I would talk to them about this and they'd say, yeah, I think you're going to have a problem with the size of your risk pool. They were right about all of it. And so early on, it was like, oh, they're right, not going to work. But then again, we said, okay, we're already losing a lot of money on Medicare members in our hospital. So then you have something that you're saying, let's reduce those losses. It's really a different conversation and a better
Yeah.
conversation,
Yeah.
right? So we formed then the Medicare Advantage Plan, which is the Aspire plan. But these are
So it
all
was sort of
great
a
plans.
natural, it was a natural evolution into that. So it's like, hey,
It
you
was,
tried to solve this one problem, you set up this experiment. Okay. Maybe it was an expensive experience, as I like to call it. You learn from
yeah.
it, and then you say, all right, now we pivot into this. How big was that population as you started ramping up the Medicare Advantage plan, and how big is it, when you
Yeah,
left?
so it's been it's slow going. There were zero Medicare Advantage plans in Monterey County when we started. So we couldn't pull Medicare Advantage members from another plan and grow that
Right.
way. So we
Mm,
had to convert people either from Medicare supplemental, which is tough. People get attached to their med sup, they like it, they know how it works. To convince people for a Medicare Advantage plan, and by the way, it was the first health maintenance organization in this county as well. So people had heard
wow.
all these horror stories like, oh my God, HMOs, I can't see my doctor. They won't approve anything. Lots of, I mean, we started there. This a community is based upon relationships. It's small enough. So we got our team and we went out and we went to meetings at churches, at community centers. I mean, we just set up all these community meetings to talk about what we were doing. When I left, so it was almost 10 years into the plan, we had just at 7,000 members, which by the way was our projected break even point. So it took us
Mhm.
longer than we thought. Um, and again, the hardest thing was just teaching people what is this product, this Medicare Advantage. We get way more traction with people aging into Medicare than people who already are on some sort of med sup.
Mm.
But over time, um, the Aspire plan has a very good solid reputation. We do not lose people, so people stay. So it's about building up traction in that plan. So it took longer than anybody thought. It took longer than
It
anybody
usually
thought to get
does.
1,000
It
members.
usually does. It
Yeah,
usually
right.
does. It's like
Yeah.
what moves fast. But think about it. That's more of a grassroots approach to building relationship equity with your community. But I think that the narrative that you were focusing is like, hey, we're trying to care for our community. Here's how we think that we can do this. And over time, because great things do take time to kind of sit and marinate, but at the same token, when you look at how today's market is with Medicare Advantage, it seems as though there's many that are popping up, and quite frankly, there's a lot of churn within plans. You start to see just how much plans spend to acquire members, and then for those members to leave. Um, that's a that's a big problem. Where do you see opportunities to innovate? Within plans in the coming years. You've obviously seen quite a bit, but where do you sort of see the trajectory headed?
Well, I think the more plans and healthcare providers work together, and then you can use innovation. So if we talk about innovation, let's talk about a couple of things we tried. Uh, some of that were very interesting. One of them was we did a study with Mayo Clinic out of Florida for meal deliveries, and it's weird, California and Florida, but I had an individual in common that was the CEO for a meal delivery company. And so they were testing, can we use this meal delivery plan, give people who are diabetic or pre-diabetic 3 months of the right kind of food that will manage their diabetes? And then will that be enough for them to develop a new habit? And so the question would be, would a plan then pay for this? Because you would save tons of money on these potentially diabetic patients, right?
That's right.
So we did that. That was really interesting and really fun to do. And 6 months, we only took it out 6 months after we ended the actual meal delivery. A1Cs were still down. So
How big was
six,
that cohort of members
yeah, that's
that
a
you did
great
this?
question. Trying to remember, one thing that was nice about working with something like Mayo is they had all the researchers who could define what's the
Yeah.
N that we need in order for it to be statistically significant and all those great
Hmm.
statistical considerations. I don't remember. I'm going to say it's somewhere around 200, something like that.
Okay. Yeah.
So,
So
right,
sizable,
so
but not so big, right?
right, but enough that you'd say, yes, did this really work? So we have this platform to try these innovations. Um, so it's that kind of innovation that we think about, which is, either innovation of an idea or new technology. We tried a new technology as well. So we did a pilot on putting um, a drug delivery sort of device in somebody's home that monitors whether or not they're taking their medication as prescribed and sends the information to a caregiver. Well,
Hmm.
for the patients we put on it made a huge difference because all of a sudden, these people on very complex medication regimens it makes it easy for them to do it. And so they are getting better. The medication's working. So there's so much mismanagement of medication, and it's very hard to track unless you have something like that. So we were able to do that. I will say the other thing that it allowed us to
Wait, can we
do,
talk
though, is
about something for a
yeah,
second? Can
sure,
we talk about something
sure,
for a second?
yeah.
Because you see a lot of attempts at doing this. What gets in the way of something sticking? Because I see and I hear and I've experienced many let's just call it proof of concepts that just don't stick. Why don't things stick? Why does it have to be so hard?
So just speaking from my experience with the organization that I was at for all those years, it's because the entire ecosystem is built around episodic fee for service care. It is difficult. I believe for something like this to stick, an organization has to have a separate, it's like almost a separate, like a separate insurance plan, but a separate business line that says all we care about is bringing innovation like this to the organization and supporting it so that and not making it anybody's side job. Why it doesn't stick is because with this pharmaceutical delivery system, it did not it was not maintained because the people who were charged with maintaining it had other jobs, and those were their main jobs. And those other jobs, they just were like, I'm so busy, I just can't be talking to patients about this device anymore because I have to talk to about the whole list of things that are on my list as a caregiver that are part of sort of standard care. I think there has to be I just think it's a problem that maybe we've all learned in business school that if you take, an industry that's been operating the same way, you almost have to, you either have to have your own internal disruptors
Right.
and they're committed to that disruption, or it just ends up becoming too much work and it's the side gig. And when the pressure's on, it goes away.
I've seen it. I've seen it on the provider side. I've seen, you see digital transformation or
Mhm.
innovation groups and transformation groups. My concern is that when you leave it up to one group or one person, one whatever it might be, it doesn't work for some reason. It just doesn't work. And it sounds great. I've seen where I've seen adoption really click is when there's two things: a cadence of accountability, and where the idea is sort of generated, by so they get the buy-in, from sort of frontline, and it's not just, hey, this is another great idea or idea of the week from leadership, and they're forcing it down. It's not a push; it's sort of a pull. That's where I've seen it work well, and I don't know if that just boils down to good leadership or what have you, but I do think that it is an element.
I think leadership is certainly a part of it, but I would say part of the leadership is, again, building this, some organizations are doing this, building this um, business unit whose only job it is to bring these ideas forward and implement them and do the hard work, because it does take work, right? One of the things with this a HIDO device, which is the medication delivery device, one of the it's change management. You have to have somebody who's talking to the patient about it. Then,
Definitely, yes.
right, right. Then you have to have somebody who's like following up. Okay, I see that this person is not taking their medication. Well, now what are we going to do about it? Who's going to call them up and say, Mr. Jones, what's happening? How come, what's happening with your medication? Can you talk to me? Or whatever the conversation needs to be. Somebody, if something, I mean, there's just there, so there's support around something new. Again, I think if there's a business unit, I mean, that would be my solution at this point. Is you say you build a business unit, and that is their only job. You
Yeah.
cannot ask incredibly busy clinicians to add one more thing. They won't. They can't. They'd love to make, but they can't. Right?
Yeah, it's like, hey, I can do this, but what 3 or 4 or 5 other things are you taking off my plate? There's always a
That's
trade-off.
right. That's right. That's right. Yeah.
So maybe let's kind of peer into the future. Like, if you had your choice in terms of picking areas, what other areas now have your focus, have your intention?
For me, it is, I'm just, after seeing how this can work and how, and physicians, by the way, that physicians and hospitals can become really closer partners when the health system doesn't own the physician group, when they're partnering. We partnered with our competitor healthcare system, co-owned this insurance plan pop health company together. I'm today passionate about this idea that if we really want to make a difference in healthcare, it's about partnership and collaboration and building connections and building relationships, not sitting across the table and being adversarial, right? Turning, former adversaries into partners. So for me, any way I can support that effort, I'm very interested in doing it. I'm an advisor to one company today, and because I think that's the only way. And I think our communities deserve it, by the way.
Yeah, I was going to say they are deserving of it. Just the fact that you say that, hey, you're in healthcare, you're trying to deliver and care for a community, and there's adversaries. It's like, well, wait a second, aren't we all trying to do this? Isn't, where is common ground? So it sounds like what you were really gifted in is your ability to find common ground. So presumably you were like the head negotiator for all of those things that you were involved in.
So I was responsible for working with the health plans, right? Negotiating, going from these horrible meetings that I hated, right?
Yeah.
Where it was just about who has the most leverage or who's willing to take this conversation to the wall, right? I mean, it felt like that. It was like this whole tense, stressful thing, too. Having this friendly conversation with somebody at the health plan to say, okay, let's try this way to keep people healthy. Let's try this way. Okay, what if we build incentives with our doctors to do this? I mean, wow, I would just sit down and go, this is what I want my life to be. This is
Yes.
fun. This is this is a healthy, helpful conversation, right?
Yeah. Yeah. How do we do that at scale? Imagine every health system had the capacity to do that. Is it just a matter of the basics of cultivating meaningful relationships with others that are on the other side of the table? Instead of having them be on the other side of the table, you come alongside of them on the same side of the table and say, what's true north? What are we trying to get to here?
It is. It is. And it's being genuine about it, right? I mean, it has to be authentic. It has to be genuine. They have to, what I was able to do is communicate that I meant it, right? That I was really serious about taking people out of the hospital as a hospital CFO. So it took a few conversations, but I would then say, but pay me to do it, right? Let's both win. Let's keep people out of the
Yeah.
hospital and we'll split the savings or something, right? We'll figure out a way where, because it has to work economically for everybody too. Nobody's going to throw themselves, sacrifice themselves financially, because then your board's just going to replace you with somebody else who doesn't do that. So there has to be that, but it can all be like you say. Yes, we are all have the same people that we're serving. The people
Mm,
who are my community members are are policyholders of Anthem and Blue Shield. So,
yeah.
right? Yeah.
What's your sense? I mean, you talk to a lot of your peers across the country, other health system CFOs, and there's quite a few challenges and headwinds that they're facing. Do you find that it's now more of just triaging problems and just staying head above water, trying to keep board of trustees happy? Where do you see leaders trying to take measured risk on doing innovative things? In what areas?
Some organizations get this concept that we're talking about, get this. We actually will all win and do better if we're doing this together, right? If we figure out
Yeah,
ways. Some do. I think it is about the culture, the where the leadership stands, right? Is there still so much distrust that the leader for one healthcare organization doesn't trust the insurers and never will? Or have they moved beyond that? And now they're saying, yeah, let's talk, let's start building trust together. And I think different organizations are on different places along that journey. I do believe that the organizations that don't adopt that are eventually going to fail, because I don't think anybody can afford that kind of healthcare system anymore. So, some will get it and some don't. And by the way, we went and studied Geisinger. So when we started down this road, we didn't create it from scratch. We said, who's doing it? Who's doing
right.
this, and who's doing it well, and who understands that where all these pieces come together. And that is exactly how, I mean, all those years ago, went to Geisinger, they had a 3-day kind of program where they talked about what they're doing. And they talked about that back then, this is the sweet spot where you have the doctors, the hospital, and the health plan with aligned incentives that we talk about today, aligned incentives, right? That's the sweet spot.
Yeah.
That's when you get traction. So they were ahead of us. We studied them. We adopted their principles. Some organizations are going to, and that, like I said, I think the ones that don't are eventually going to be bought by somebody else or found.
Hmm. And did you find that others had a natural sense of curiosity into what you were doing, some of your peers, and how were you guys similar to Geisinger, where you were a bit of an open book and saying, yeah, sure, we're happy to share what we're doing? I guess how close to the vest do you hold things, or do you have
We
more
were
of this
very,
abundance mindset?
no, very open, right? Because we were very open about this. And I did, I did talks at different conferences, and would talk about and would map out everything we're doing. Not a ton of people, though. They said, oh, wow, that's really interesting. And maybe because I would always use Geisinger with their permission, by the way. So I had the
Yeah.
slide that I'm going to tell everybody, and they're like, yeah, we want you to share it. um, maybe that's where they went, and which is fine with me. I mean,
Yeah,
again, if my interest was only that this become the way people think about healthcare delivery. Like, I don't care who's doing it or how, just do it, right? Just
yeah.
because it's really what matters.
So how do folks follow the work that you're doing, in terms of your story? Maybe give a little bit of a commercial in terms of what your areas of focus are and how people can kind of stay in touch with you.
Well, I'm on LinkedIn, right? So that's the thing. I mean, I'm on LinkedIn. I don't have a website, but I think that's really where people can kind of track what I'm doing. They want to reach out to me, or yeah. So,
Sure. And I guess as the community, how else can we support you? What are some things that we can support you on?
well, Michael, thank you for this opportunity. This is great. And I'm going to, outside of this, introduce you to some people who I think are doing some interesting work, right?
That's
I mean, I
that's
think
good. That's
that's it,
always helpful. Thank you.
right? It's like, so we build this network and connections and talk to each other. And, you know, maybe, and I'm happy to talk to anybody at any time. So if they want to reach out to me. And, uh, you know, if somebody today went, oh, this is really interesting, I'm happy to share more details, kind of get into the nitty gritty of it. I did not know how to, I'll just say this too. I did not know how to run a health plan. So I hired somebody who did. I hired a chief operating officer. I hired a consultant who was very good at saying, here's how you start an insurance company from scratch. Here's your recipe. I mean, right? So
Yeah.
bring people in who know how to do these things if you don't, right?
Yeah, exactly. It'll shorten the timetable for sure, and
Yeah.
it'll heighten your chances of success.
Yes.
It's what any good, savvy business professional would do, right? Is build a good team and
Right.
share the
That's right.
vision. So Laura, it's been really nice to have you on the show. So for those that have tuned in, if you found this conversation enlightening, if you found it helpful, would you mind sharing it on your social media, liking it, engaging with it, commenting on it, or even just shooting us a note to let us know what you thought about it and maybe some of the things that you're going to take from it. So great having you on, Laura, and the door is always open to have
Great.
you come back on and maybe share some additional learnings.
Thank you, Michael. I really appreciate that. And I really do appreciate this opportunity to share the message, if you will.
Of
All right.
course, it's my pleasure.